was a critical care tradition that ventilators had to be on the right side of the patient. And you may, in fact, know others from your practice. So the vent on the right, it was something that was taught from nurse to nurse. We put the vent on the right side of the bed. And then some years we created 3 new critical care units, brand spanking new from the one unit that we had. And the configuration was completely different. And where you could put the equipment was really changed from where it was in the traditional unit. And so new nurses, because that's what you're going to be, and you're going to have questions like this, you're going to say, why do we need to put the vent on the right when it seems like it would be more comfortable taking care of this patient for this to be in a different place? And what we found out is that in the old unit, the red plugs, which are the plugs that don't go out even if you lose power, were on the right side of the bed. And that's why the vent went on the right. So there was absolutely no clinical reason for the right side, but there was a great reason to plug the ventilator into a red plug. So the application question is trying to get you to answer the question based on what you learn and what you have read, and then apply it to a setting. So after this story, in a hospital, nursing care tradition dictates that ventilators be placed on the right side of the bed. This is most likely an example of which of the following phenomena: the prioritization of internal evidence over external evidence, practice that lacks evidence to support its application, the integration of personal expertise into nursing care, or evidence-based practice. Now, after my lovely story, what is your answer? B. Thank you, Amy. Practice that lacks evidence to support its application. And that's what nursing care traditions really mean. The other thing that you should review and know about is validity, both internal validity and external validity. So internal validity are ways that people, researchers, make sure that the intervention is what caused the change, not something else. And so it may be that one unit that it was tested on was so different than another unit that it worked in one unit and not in the other unit, or the groups were different, or the environment was different. It could be all sorts of internal things at the place of the study that could support or not support, could be a risk to internal validity. External validity is generalizability of a research study. So when you do power analysis, when you randomize, when you use tools, measures, surveys that are validated on a national level or international level in many studies, that supports the external validity coming from the outside, the external validity of a study. So the application question: a nurse scientist is conducting a randomized control trial to test whether acceptance control therapy is effective to support self-management. To enhance the validity of the study, participants were matched in each group for certain characteristics that might influence the results. So this scientist is trying to support what type of validity? Is it construct validity, internal validity, statistical conclusion validity, or external? Correct, internal validity. We're all getting it. I hope I didn't put B for every answer. I guess I wasn't thinking through that, but it wouldn't have been my intent. Well, I'll laugh if all my answers are B. That's not true, by the way. In the exam, all the answers are not B, and they're randomized per person. So just so you know, if I somehow did this, so it's internal validity. Another question, a nurse scientist is interested in nurses' experience with transitioning to a new job. To support the generalizability of the results, a reliable and valid survey related to nurse transition was chosen for this study. Using this survey enhances what type of validity? Is it construct validity, internal validity, statistical conclusion, or external? My friend Jennifer, Megan, everybody's getting deep. Thank you very much. And so, obviously, when we're going through this, we're seeing is that if you know this information, these application questions aren't really that hard. They make sense based on what you read. And so if you do review these, if you review your practice questions and the chapter that support them in the book, you're going to be well set up for this test. So external. So threats to internal validity, those are also in the book. There's history, meaning external events happen at the same time as the study, and that changes the outcome from the usual. Testing, if they repeat tests, sometimes that changes the results because they're testing and then they take it another time and it's not quite as valid. Attrition, whether they're dropping out or whether patients die. What's different about that makes people want to leave a study? And maturation is over time, and that could be age, like they've grown up, they were little kids and now they're teenagers, or it can be competence. So they were a brand new nurse a year ago and now they're a competent nurse and they're not going to answer things in the same way. So a study related people began for the COVID-19 pandemic. Threat does this represent? Is that attrition or maturation? Asha says C. Oh, look at you guys. History is exactly right. I can tell you, if you just want to preen a little bit.
Joan, can I interrupt one second?
Go ahead.
And I might have missed this at the beginning because we had connectivity problems out here. But did you press the record button? I noticed a number of students are wondering if it's being recorded.
And I don't see a record button. So can you tell me why I don't see a record button?
It should have been at the very first home screen. Sorry. So it wasn't when you signed in at the first home screen?
It didn't say anything.
Okay.
Now, I had to go out and in, and I might have done something funny. But if I can't see it, I don't know why.
So it has to be something with the system then. Okay, so just know that right now it's not being recorded.
It's not.
So if
and I can absolutely send out the PowerPoint, and if
I'm thinking if they wanted to record it, you could record it via your phone next to the. I've done that already in a pitch, so that's another way for if anyone's interested.
No, I appreciate you bringing that because people were asking, and I couldn't. In fact, that's what got us a little late because then I tried to go in where it was when I did it by myself, and it wasn't there to choose, and then it took me out. Anyway, long, boring story, but now we're here. And we'll
they're getting the PowerPoint, so that's a good thing. Okay, yeah. Thanks. Okay, I was silent again.
No, it's fine. So what I was going to tell you was that I have been using this test for a few semesters now. You guys, I get it. Banking on, yeah. I'll try to figure out what I can do to make sure people get this information. You guys are doing a great job, by the way, is what I was trying to say. It's because I have used to silence before, and people were very nervous in trying to answer it for jumping in. So this is the levels of evidence that I had actually presented a few weeks ago to my group, and this is from page 18 of 9, and I'm not going to go through all these again. I'm bringing it up right now because it is important for you to know that level 1, the systematic review and meta-analysis, is the highest level of for quantitative studies. So if you have a good systematic review of randomized controlled trials, that's the highest level of this that you can use. Level 2, randomized controlled trials, is the next highest level, but a strong RCT still doesn't beat a study full of RCTs. Level 3, non-randomized controlled trials. Level 4, case control or cohort. Level 5, systematic review, descriptive and metasynthesis of qualitative studies. And level 6 is descriptive and qualitative studies. Now, it doesn't mean that any of these are bad, but what the levels tell you is how strong the evidence is. And this will be particularly important when you, for this class, it'll be important when you're writing up your paper, because you'll put more stock in evidence if it's at a higher level. It will also be important if you're looking to make a practice change, because then you'll know there's enough evidence for making that change. Right now, you guys are looking at a systematic review, and I'm here to tell you, we were talking about that this week. You know, systematic reviews are not that easy to read, and so I'm going to talk a little bit more systematic reviews, but just know that they are the highest level. So why are they the highest level? When they make you crazy sometimes when you read them and you read all the way through and they tell you, so there's not more research is needed. And you think, you were 57 pages. You're big and you didn't tell me anything. So the thing about them, though, is they are a review of all the evidence available, some time frame, because if there was one done 5 years ago, they might do all the studies. But their rigorous search, results, and appraisal includes all randomized criteria, reduces the risk of bias, and it uses a statistical approach to synthesize results across all studies. And that is that synthesis across all studies. So it's a huge study. Application question. A clinical practice identifies that their central line infection rate is higher than other units with the same population. Which of the following were used to determine the best recommendations for change? Would they look for traditional practices, evidence from a systematic review and or meta-analysis of relevant RCTs, a systematic or cohort studies without the use of control group? And B. Look at that, I'm on B again. Yes. Okay. And the thing that I want you, when you have systematic review, the most important thing to pay attention to is what's called a forest plot. And this is in your book. And there's also a very good Schoenfeld video about the forest plot. The thing about this is it is a quick visual. Even though the article can be messy, the forest plot itself tells you yes or no whether there's enough evidence. So if you look at this forest plot, this line down the center means no difference between using chlorhexidine or not. So there's a couple studies that are right on this line, so that you would have said there is no difference. And there's even one over here that actually says there's the comparison. But when you look across all of the studies and do the statistical analysis, is this little diamond here shows you that across all studies, when they look at all the data, it actually favors using chlorhexidine. So they're enough. Look at crawl significant at 0.020. The systematic review showed that there was evidence for a practice change. Here, randomization. I'm going to see this again and again in the questions, because randomization is really important for quantitative studies because it's used. Control trials are prospective, meaning they are looking forward in time, and at the end they actually predict cause and effect of the treatment that you're testing, and this supports your internal validity. Randomization is the most important strategy to ensure the integrity of the experimental design. It compares treatment to control, it minimizes bias, it minimizes confounding factors, and randomization is more important than a large number. Look at 50,000, but if it's not randomized, it still is not going to predict the cause, that the treatment is the cause. A nurse is searching for recent information concerning the most effective method to use to support hypertensive women during pregnancy by testing their blood sugar. Which of the following questions is the nurse to consider when appraising a study? So this is doing what you're doing and looking at the study. Were the control groups from my area? Did the study cover at least a year follow-up? Were the subjects randomly assigned to a group, or will these methods be effective for everyone? And C, everybody's saying, and you're exactly right. And I didn't say B again, so there you go. Randomized control tests, all do randomized control trials, is difficult to do, especially in a clinical setting. They're expensive, and give you a bunch of money unless you have a really good proof of concept. You usually start with a pilot study, which is a small number. Test if it'll work in the setting or population. You need dedicated researchers and funding to complete a randomized control trial. Even with enough numbers, it's still a big job. And sometimes it's not logistical or to withhold treatment from one group. And so that's why you'll see some things that are control trials, which is level 3. And we'll talk about that a little bit later. But imagine, though, if you were giving care on one unit. There's just no way you could randomize the care that you give on one hospital unit. That wouldn't work. Sometimes what they do is do like a pragmatic randomization where there'll be like units in other hospitals and they'll randomly choose which one. But the main thing is you'll never be able to do this unless you do some kind of pilot and show that you have some reason to think that with more participants that you'll get better results. So clinical nurse specialists would like to implement a postpartum care bundle to reduce the need for opioids at discharge from one postpartum unit in a health system. The Department of Nursing advised they conduct a pilot study prior to the commencement of a large multi-site quantitative research project to implement this across the health system. Is used primarily to inform the parameters of parameters of a larger study? The relative feasibility, ethics, or generalizability? Jennifer says B. Looks like people are on the bandwagon, and I apparently B. So there we go. A nurse educator wrote a proposal for a quasi-experimental study that tests the effect of simulation-based mock code teaching on nursing skills and outcomes of resuscitations. Which of the following is a characteristic of a quasi-experimental study? So this is not a true experimental, but a quasi-experimental. The design includes a post-test but does not apply a pre-test. Participants are assigned by a method other than random assignments. The results of the description but do not identify association. And the effects of intervention are identified by examining characteristics of participant histories. And Tasha's got me. And it's B again. Okay, I'm going to change next time. I have no idea I got to B for all these answers. But anyway, exactly. Participants are assigned by groups other than random assignment. The first one, a post-test that doesn't have a pre-test, is not even a study. And description is a descriptive study, but it's not randomized control. And then this whole business about looking at the characteristics of participants' history, that's a case control study. So type 1 versus type 2, this is something that you do need to know about. Type 1 error is a false positive. And this could be the result of using a large sample, because you're actually looking at 50,000. Even a small, insignificant clinically change is often going to be statistically significant, even though it really has no meaning. And a type 2 error is a false negative. There's a difference in the intervention. So you see a clinical difference. You see people getting better, but there's no statistical difference. And that sometimes happens because the sample was just too small to discern the difference. And that's why you need to do a power analysis so that you know you have enough of a sample. So a power analysis is a statistical analysis to find the number of participants needed, a large enough sample to ensure that there can be meaningful assessment of the effect of innovation. Now, that doesn't mean that there couldn't still be an error. It just means that this is our best guess about how many we need, because sometimes effect sizes are there. But this should be, you should see this in the methods. You should find out, what the power analysis was. But sometimes it's not reported, and you noticed already that it's not always reported. And so if it's not, it's a limitation, and you can't really know if the results are valid because you don't know if they had enough of a sample. So although participants were randomized, the researchers were not able to recruit the participants that were recommended. And this actually happens more than you think. Even if you have the money people to part of the study. They didn't have enough for the power that were recommended in this insertion device. What kind of error are they worried might be? That the researchers may have concluded that the device is an improvement when in fact it is not. The team could have concluded that the device was not, in fact it was. The nurses may have committed a type 1 error and the construct validity would be lacking. And we're all saying B because why not? It's always the answer. Please don't choose B on all the answers of the test, because I swear to you it's not. Okay. Since the sample size of the study was smaller than recommended, there was no significant difference in the outcomes of the treatment and control group. A different question. So the sample size smaller, and so if a sample size is what type of validity was affected by this? And I'll tell you a story about this one. So see how this goes. I hope the answer isn't B. Okay. So is it construct validity, internal validity, external validity, or statistical conclusion validity? And look at this. Megan and Tasha, you guys are fine today. And the answer is yes. It's statistical conclusion validity. So again, construct validity is that the tool measures what it's supposed to measure. Internal and external validity we already talked about, and statistical conclusion validity is the inferences of the statistical analysis are correct. Can't be correct if you're not using the statistical. If your power analysis says you need 87 and you have 67, you can't have a conclusion in that respect. Theoretical frameworks. Now, theoretical frameworks are sort of big ideas that describe theories related to process or system that guide the variables of the study. And they're usually clinical based, so they're based on things that work in different situations. So, for example, I work in diabetes, and the chronic care model is nationally supported as a model that describes the elements that are needed to support improved outcomes for people with diabetes. And that was shown in a systematic, and so the national guidelines use the chronic care model. So here's what it is. And these are the kinds of things for diabetes that matter. Self-management support, delivery system design, decision support, clinical information. And so if you were coming up with a study, you should have things that when you're looking at your variables. Here's the question. A nurse submitted a proposal for conducting a study looking at the use of specific exercise to decrease the average blood sugar for people with type 2 diabetes. The proposal was rejected because no theoretical framework was included. Why should the nurse include this framework? Identifies potential ethical issues, limits the variables in the study, establishes the best study, or assists in selecting studies variables. And Tasha and Megan, Amy, there you are. Yes, it assists in selecting the study's variables. So evidence-based practice is, for the best evidence, changing practice in a systematic way. That evidence from research experts combine the team, the type of patients and the resources available. You then adapt it for the workflow while you're honoring your patient's preference values at the individual patient level. It does no good if you have an absolutely evidence-based and that patient is absolutely unwilling to participate in. If they say no, that's the end of the story. You cannot force intervention on a patient. So the bottom line is it still has to align with the patient's values. It's sustaining processes and adapting locally, gathering clinical outcome data, and disseminating that data to team, your health system, local, national channels. And so I actually focused on a lot of the questions that historically people get wrong, that it's completely inclusive of all the questions. Between the questions that I gave you, we all gave you along the way to practice with, looking at these questions, that should really help you, as well as looking at those chapters in your book, and just making sure that you have a good idea from your study guide about all the different things listed on that list. Any other questions about the test itself you would like to have us answer? Oh, lockdown. Is anybody going to ask that? I did put that question out there today. It's still open book. And what I asked about whether or not the test could be shrunk down, you could look at desktops or do anything. I did request that if that was not possible, that they not did a lockdown browser. So I did not hear back from them today. I sent it this morning. But I do know that the faculty have a meeting tomorrow about exams. And so I will get that answer to you, or it's either the answer is that you still will be able to get your computer, or B, we're going to tell them to shut down the lockdown browser. You should have everything you need for this test in your book or your notes. It's still okay to have iPads, ebook, and notes. That's what open book means. So you can do that, but don't think that it'll be easy to find these answers if you prep them. If you prep them, you're going to remember where they are. Have not prepped them, it'll take you too long to find them in the time that you have. So do still study. And any the systematic you're reviewing this week. The exam is scheduled for Thursday, right? Next Thursday till 10 a.m. You'll all end next Thursday from 8 to 10. Yes, you're allowed 2 hours. Most take about a little hour to take the test, but you get hours, so you'll have plenty of time to carefully read the answers carefully, and you're welcome. Anything else about somebody else? A couple people. Yes, it's 40 questions. Dr. Miles and Dr. Kosmowski Geffert, is there anything to? Oh, is it 8:30? You know what? I would have to look it up. It's on your syllabus. I thought it was 8 o'clock. 8:30? The last randomized we got with scenarios did not go smoothly.
I can verify it is 8:30.
Oh, it is 8:30. It's 8:30 to 10:30?
To 10:30 on the 22nd of July. Yes.
Thank you, Julissa. Sorry that I missed.
Okay. What was the other question listed?
The other question said the last randomized exam we got with scenarios did not go smooth. What didn't work with that? What happened? Because I've never had any problems with this exam.
I'm just gonna unmute. We had a test that had like scenarios given to us, and then like the next couple questions were supposed to be on that scenario, and they got scrambled.
Backwards.
So the scenario that we saw like came in questions sometimes.
So it is true you can't go backwards, but there's nothing in the question that you'll have to know for another question. So it's going to be just like this, where the whole story is up there. You'll read it, and then you'll choose A, B, C, or D. Thanks for bringing that up. What's the design of the study that you're doing an appraisal for this week? Systematic review, yay! And what level of evidence is it? Thank you, level 1. Design and method, column. Well, not entirely. Exclusion, what kind of search is in your midst. Because it's a systematic review, it's the search that's the method, so the searching papers. So in your paper, as far as the evidence tables, you do the reason that you're writing evidence is actually to write your paper. So the evidence tables, think of it as where you're holding facts for writing your paper. So at the very least, you would know what the design of your study was, what level of evidence you had, a very brief, yes, absolutely, I suggest doing those first. We're going to look at those across studies and come up with themes for your outcomes. And so what you do will depend on how you're assessing your evidence tables. I'm glad you asked that, Courtney, because that's why we actually have you learn how to assess first.
So, and Joan, I just wanted to add something to that too. I think I told my students is exactly what you just said, that so better that you do those evidence tables, and if you're really clear, you put your notes in there. It's kind of like you're taking notes in a very structured way.
And you're writing it for yourself, not for others.
Right. And so then when you go to do your paper, if you don't have to go back and plow through all those studies again. And gosh, I know I read the sentence somewhere. You know, if you pick up the really good information when you're completing those evidence tables, it's going to be right there in your evidence table. And that doesn't mean you need to rewrite the whole article on your evidence table. It just you need to really zero in on what's most important. And so that when you go to write it, you'll be right there at your fingertips.
Right, and the findings on that evidence table should, for your paper, for the significant findings, just write the significant findings that pertain to your topic. Because as you've seen from the RCAs that you've been doing already, there's a lot of significant findings, but because you're learning how to do it, you've been having to include the findings because they're not related to a particular PICO. But when you're doing your tables for your paper, the only thing you have to list under the findings column is what's significant with respect to the PICO you chose.
So, for example, let's say your PICO question was, does the use of a buzzy bee decrease pain in children? Your evidence table for the RCT that you just completed wouldn't have included all the anxiety and other things. It would have just gave significance of the pain and the measure for pain from that study, because what was answering the question. So you don't have to have all the answers, just the ones that Dr. Gephardt already said. Big long name.
Ms. Gephardt, it's fine.
Okay.
As I've just said to my group all along, while you're doing hopefully you all, as you were possibly over the last, ideally you were also doing EA for an article of the same type that you might have been using for your paper, because just a warning, and I know we've all said it, but I'm going to say it again, as you found out, RCAs take time to do correctly, and if you do them correctly, writing the paper will be pretty easy. I mean, it just facilitates you to write the paper easily. And so if you're waiting to do your RCAs until the night before the paper's due maybe, or maybe 72 hours before, that's going to be quite a challenge. So if you haven't started already, really look at your timeline. And we do recognize you guys are all in exams and other courses as well. You know, try to keep up as well with at least one RCA, or, you know, try to strictly plan how you're prepping.
And there was a question about splitting up the two people's writing skills combined. So really, when two people are writing, there's different ways to do it. So sometimes people do split it up. Usually you have to do just like you had to for your discussion, which is why that was a discussion. You're supposed to you both did a search and then you sort of merge that together in your method section. But sometimes one person will take the background and significance and the other one will write the results. But the truth is you both need to be proving the whole paper. Even if you just write part of the paper, you should be looking at the whole paper because it's really hard to edit your own work because you add words that are missing, you don't know words that are missing. It's just, if you're writing and usually you've done a couple drafts already, it's really hard to edit your own work. So even if you split up sections, you still be reviewing each other's section. And when it comes to the themes for your results, it would be good for a session with both of you and your evidence tables. Highlight what the themes are. Okay, I've got an article that's talking about this theme from our study. How do we put those together?
Right, and adding, I would say that the final product sound like it came from one person, and so that's part of the fact you're collaborating to write it. You might split up sections, but there needs to be responsibility amongst the two of you to make sure that it sounds like it's just coming from one.
Right.
That the verb tenses follow, etc. Otherwise, it's really not level paper because it doesn't flow or sound like it.
That's exactly right. I was going to say the same thing,
right,
Dr. Gephardt. And first thing, from a grading standpoint, when you're reading a paper like this, you can go, "Oh my gosh, it's like I have one paper here and one paper here," and they don't really fit together very well, and it's very hard to find how to grade it. The more you can do to blend it together and a given kind of thing is really important.
And let's say that if any of you are having trouble coming to a consensus about what you want to say in your paper, or even how to get started, sometimes you need a little help integrating your themes or integrating your ideas. Do not hesitate to set up a one-on-one meeting with your faculty. Mm-hmm. Can we do a little meeting tomorrow? Yeah, we can do a little meeting tomorrow. I'm happy to meet with groups one-on-one and talk through a paper. And do not panic. No. First of all, this is a paper. This is not life and death. Don't panic. No. That big of a paper. I hope it will be fun for you to write, but the more systematically you do it, I've been panicking since the beginning. You guys, you'll get through it. And if you need help, we'll help you through it. And you're also for that first, essentially, paper one is a first draft. And you're going to get tons of feedback on that paper, and it's formative. You won't get a grade for the first paper. You will do your best. Don't panic since 2020. Not about this. And a paper, you'll take all our feedback and you'll pop and you'll make this beautiful final paper. So don't be worried about this paper. We want you to learn how to look at these articles, choose research you can, put it together. And if you don't find enough evidence to support a practice change, you say, not enough evidence to support a change about this topic. An A paper can have no results. A systematic review with no significant results can be published. So know that it's not your answer. It's how you write it, how you've researched it, how you've written your results, how you've pulled it together, that's what your grade will be. So please connect with us if you need help. We're happy to meet with you. We're happy to talk to you about it.
And I'm just going to say kind of what Joan just said, because really what you're doing, like she said, it doesn't matter what your result is, whether there's enough there or there's not enough there to support the exchange. But what you're doing is that you demonstrate that you can do this, that you know how to find the articles, that you know how to critique them, and you pull it all together. So that's what's important.
Yeah. And it is our goal that you are successful, at your papers are a thing to be. And we would like to help you do that. And we would like to actually read a paper like that. So,
And I would probably have read some beautiful papers. So
absolutely.
This is beyond any of you, really, because it's, in fact, you've probably done papers. You've had for most of your papers, and it's taking a position. You know, the difference here is you're evaluating the evidence in terms of, and that conclusion, right, is you're supporting a practice change because the evidence is valid and reliable, and it's substantial, and it's got to be applicable too. You don't support a practice change, or you would like but more in a particular area move forward. We're looking at results.
And if that something working with your partner, both of we need to talk about what it is that you're finding that you don't agree with, and I can't do that in this venue, but I will do that one-on-one with you to figure out what it is that you need, because there are research that contradicts each other on about the same thing. So if you're writing the paragraph, the only way you can say was this study was conducted and found this, and in contrast, another study found the opposite. So in that way, if you have research that supports an opposite view, yes, you can report it, because that means you don't have any clear research that tells you what the answer is. So let's take that stuff offline and talk with partners together and see what's going on there. And that can only really be done with your faculty one-on-one. Anything else? We're almost to the end of our time.
Okay, what's your exam in tomorrow, everybody?
Maternity.
Oh man, okay, so I'm typing. It's like multiple courses. No, maternity, labor and delivery. Okay, specifically the labor part. Okay, so you're laboring through all your assignments. We all wish you the best of luck. You know, center yourself, think clearly, look at those questions, and only answer the question that's being asked, because it's really easy to start thinking what's happened in clinical. Don't do it. Just answer the question that's on that paper.
That is the most important thing to keep in mind.
Mm-hmm.
And it seemed like there was one or two people that were recording this, and if they would be willing to share the recording with me, I could make sure that everybody gets it. Thank you.
Thanks,
I really appreciate that, Rachel. Okay, if there's nothing else, how about we go and study maternity? And
Good luck to everybody. Reach out if needed. Okay, take care.
Absolutely.
Bye.
Bye.